webinar. My name is Meg Beyer, and I'm part of the Managed Care Technical Assistance team. I am happy to be joined by colleagues from OASAS and OMH today. Again, our topic for today's webinar is telehealth for OMH and OASAS providers during the COVID-19 state of emergency. Just a few things before we get kicked off with the content for today, just some housekeeping reminders. So today's webinar is going to be recorded. The slides and the recording will both be posted to the MCTAC website and also distributed via email. We want to encourage you to distribute these and share these widely amongst your fellow colleagues at your organization and agency. We know not everyone is able to join today's webinar, so that's again why we're recording it, and we'll be posting it along with the slides online. The other thing that we're doing slightly different from our traditional MCTAC webinar approach is that we are asking you to chat in all of your questions today. We know there's probably a lot out there, and we're going to be collecting all of them. We are not going to have time today on the webinar to address these questions, but instead, we've scheduled a separate webinar tomorrow at the same time at 1 o'clock, where our state partners and MCTAC will again join, and we will try and address all of the questions that come in. So we want to encourage you to chat in your questions throughout the webinar today. We're collecting them all, we're organizing them, and then tomorrow we meet back here at 1 o'clock and we try and address all of the questions. So even though we're not answering the questions in live time today, we have scheduled a webinar in less than 24 hours from now to address all of the questions that come in. So with that, I want to thank our partners at OMH and OASAS who pulled this together. And I would like to ask our OASAS partners to introduce themselves and take us through their portion of the presentation.
Thanks, Meg. So I'm Rob Kent. I'm the General Counsel at the New York State Office of Addiction Services and Support. And I'm socially distanced, but in the same room with...
Tricia Shelguy, Deputy Counsel at OASAS.
Keith McCarthy, Associate Commissioner for Quality Assurance and Performance Improvement.
Anna Pulaski, Director of Certification.
Great. So thank you all. Okay, now I gotta, okay. I'm controlling the slides I am. Here we go. Telehealth for OASAS providers. So first off, I just want to thank folks for getting on the call. Want to commend you for the work you're doing. We know we're in extraordinary times and it's difficult enough to work with the folks we care about. In normal circumstances, we are not in that. So we appreciate everything that you are doing. So I want to go through some slides quickly. All of the guidance that we've issued is on our web. It's available. So with that, I'll kick in. So we've issued 3 telepractice specific documents. 2 of them are guidance or regulatory waiver documents, and 1 is an attestation document. Again, they're all found on our website. So to the extent we've issued guidance, it does supersede any other guidance that we may have issued. Our guidance, obviously, or maybe not obviously, so I'll speak clearly, it applies to our OASAS certified, funded, and authorized, otherwise authorized programs. We don't regulate private practitioners. And then the guidance, again, as I've just said, it applies there. And so with the 2 components, effectively what OASAS has done with our regulatory guidance waivers, our guidance documents, our regulations were already expansive in the ways that we allowed telepractice to be provided. And what we did, though, in the midst of the governor's declaration of an emergency, we have basically front-loaded approval and designation. You submit your attestation, you are approved when you get a responsive email, which everyone gets an acknowledgement email, you're approved to do it on filing of the attestation. So that was one component. The second component was that we allow for telephonic telepractice, and that's by permission or in consultation with Department of Health and with review of updated federal permissions that have been received. So you can do the services telephonically, or you can do them through the traditional telepractice, which is a combination of audio and visual. And here are the links on this page to all of the documents I just described. So some of what I hope we do is avoid FAQs by answering questions in our affirmative, delivery. So you don't need to submit one attestation for each PRU. The program itself, the provider can submit one, and it authorizes all of their programs to do this. As I indicated, your approval occurs upon submission of the self-attestation. Just to be clear as well, these approvals or waivers are time limited and effective only during the disaster emergency which the governor has issued. Programs agencies already designated to provide telehealth don't need the additional approvals. You would also then, just to be clear, benefit from the expanded approvals we have, but you already have approval to do telehealth. So for instance, you could now do telephonic because you've been approved to do telehealth before that. Okay, I'm controlling the slides, or so we think. Telehealth for Medicaid reimbursable services, again, is temporarily expanded and includes the two-way audio video and video, including technology commonly available on smartphones or other devices. And as I indicated, we're allowing telephonic communication. Services to be delivered are those allowable under current program regulations or state-issued guidance as clinically appropriate, and include assessment. So I know one of the questions we've received, can I do assessments and have this count as the face-to-face, which we require in our regs? The answer is yes. Individual, group, medication management, and collateral services, all of the services can be provided through telehealth, be it audio-visual, traditional telehealth, or the telephonic. So that's not changed. Those are permissible, those are reimbursable. I know one of the questions we're getting is whether peer support services or SERPA work, engagement, and outreach, they are not currently included. We're working with our partners in state and federal government to determine whether or not those could be reimbursable through telephonic in particular, but at the current time, they are not covered. And I'm going to be clever and tell you, you can still provide those services. Covered means you can't seek reimbursement for them, but as I said, we are working on those. Okay. Again, telepractice is not a service. It's a means of delivering the services we already ask you to provide. The guidance does not change reimbursement amounts, nor the requirements otherwise for Medicaid or commercial reimbursement. And here's something that I spend every day thinking about: claim modifiers. I'll read this because I don't know what it means, thank God. Claim modifiers 95 or GT should be used for services delivered via telehealth and reimbursed by Medicaid. And one other critical element is that commercial insurers regulated by New York State must provide reimbursement for services delivered via telepractice if those services would have been covered face-to-face. And right now, under a circular letter that the Department of Financial Services issued over the weekend based on a governor's executive order, they are required to waive copays. But just let me be really clear, these are commercial insurers regulated by New York State. Not every insurance policy in the commercial market that is issued in New York State or issued to New York State residents is subject to our laws. you can read that circular letter from DFS. The link is there. And you can reach out and get assistance from them beyond that. And I know we're going to do FAQs, but before we do, we're going to do some at the back end where we try to answer some of the questions we're getting frequently, both agencies. So I'm going to ask my colleagues, did I miss anything you think we should hit on before we turn it over to our partners at OMH? We'll wait and do the FAQs. I think we do them jointly at the back end. Oh yeah, on the consent issue Keith just raised, we're getting asked, we know how much confidentiality and consent are issues in our system. We've been asked, do I need written consent? Ideally, you get written consent to do either the traditional telepractice or the telephonic. We want to be clear though, you can get verbal consent. You should document it in the record that you received the consent, and you should, ideally follow up and get the provider, get the patient to sign a consent document, but we will not ding you for that. And I just, before I turn it over to our colleagues, I just want to make it clear to the OASAS providers, every provider should be applying for a telepractice waiver, filing that attestation. Every, not just ambulatory, every provider. Think through what's going on. You're going to have staff in a bedded program who do clinical reimbursable services who might not be able to come to work because they've been exposed or have the virus, or their kids are out of school and they don't have daycare. You could have them work remotely, telephonically or otherwise, and actually call in to the program. So you need to think that through. I just believe every provider, there's no harm in getting this approval right now. And because it's going to lead you to, be able to continue to help people, which we know you care about helping. And we're doing this as well because we don't want programs to close. That doesn't mean we're asking you to have people show up every day at your building. We're not. Obviously, there's rules being put into place that speak otherwise. But the ability to continue to engage folks who are in your care is critical. We want you to get paid for doing that work. I would just strongly encourage every OASAS certified provider to submit an attestation and get the approval and take advantage of the authorities that we've given you at this point. One last thing I wanted to say, there seems to be some confusion about the locations where this can be done. You don't need to be in a treatment program, a certified site. The doctor, the prescriber, the counselor can be in their home. The patient can be in their home. And with regard to technologies, you can use any that are available. There are plenty, and I don't encourage or discourage use of any. I don't endorse products, but there are products out there that would allow you to do group counseling sessions via telepractice, and you should take advantage of those. Again, we want you to engage clients. We want you to take advantage of what we've already authorized. We just wanted to accelerate the approvals, and we were able, thankfully, with our partners in state government to get expanded authority to, at least during the emergency, do it telephonically. So with that, I will stop talking, and I will turn it over to our colleagues at the Office of Mental Health.
Thank you, Rob. This is Bob Meyers. I'm the Senior Deputy Commissioner at OMH. I'm going to just do some introductory comments, and then Nicole Haggerty and Amy Smith will be going through our presentation. And basically everything Rob said is ditto for the Office of Mental Health. I wanted to start out by thanking all the providers on the phone for stepping up in these extraordinary times. I know you're all organizations and your mission statements and your dedication, and this is exactly the type of thing that we signed on for on the front end. One point Rob made, you just know the anxiety that's out there now. I think we're all feeling it. I actually have some staff that are actually having anxiety symptoms, but they've never had them before, and have even sought some treatment. So you could imagine the impact this must be having on the clients you serve with depression, anxiety disorders, bipolar disorders, thought disorders, trauma. So it's just very, very important that they continue to have access to the good care you provide, both the therapeutic and support care and the pharmacology care, which is why we were so pleased when we were able to issue the teleguidance and expand it. I've been hearing some things, and I have no idea how many of you this applies to, but I just wanted to make it clear that by issuing this guidance, you're not closing your clinic. It's the opposite. You're able to create a virtual clinic in these difficult times so that we can maintain social distancing and still provide care. So following what Rob said, I would encourage everybody to apply and then to figure out how to properly implement it. Our guidance has loosened up significantly. Along those lines, we're going to be revising the guidance we already have out there, because we did get a question about some of you have clinicians that actually live in Connecticut or New Jersey and come to your office every day to work, and can they do this from home other than prescribers? And we are going to be allowing that. We'll be revising the guidance, and we'll address that more tomorrow. The other thing I've been hearing from some hospitals is that some clinics are saying they're not taking new referrals. You can't close admissions. You have to provide ongoing access. If you're part of an ecosystem, and if the hospitals can't hand off people to you to assist them in the community, they're going to back up, and we all know what we're expecting to happen to hospital capacity. So by getting the tele approved, it doesn't authorize you to close admissions. It's almost the opposite. You're just going to have to think through clinically how you would go through the assessment process from a tele perspective to determine the proper course of treatment, both from a pharmacological and from a therapy perspective. The other thing I wanted to mention is medications. I hope you're trying to communicate with the pharmacies that you use. Many pharmacies do deliver medications, and as time proceeds and you have a sense of the scripts that are filled and when they're due, please pay attention to some of your clients that may run out of medication. Some of them have natural support systems, or they could get them themselves. But for folks that you're concerned about, that's just obviously a very critical piece to pay attention to. One more thing, we are going to be issuing guidance on housing programs that aren't billing Medicaid, or housing programs that have 24-hour care, and that'll be coming out soon. And we're also going to be issuing guidance on deficit-funded programs that don't bill Medicaid, but you're supposed to be doing face-to-face work. And to the extent that you could do tele there, that would be fine. Tomorrow, again, we'll be addressing many of your questions, but I'm going to turn it over to Nicole and to Amy now. Thank you all again.
Thank you, Bob. This is Amy Smith. I work in the Bureau of Inspection and Certification here at OMH, and we do want to take this time to, focus on the telemental health guidance that we've released to date. You're going to see a lot of overlap with what OASAS has presented already. So just to highlight, similar to OASAS, we've expanded our telemental health guidance. It supersedes any other state-issued telehealth guidance. It does apply only to our OMH licensed and OMH designated programs and services. The OMH Telemental Health guidance does not apply to private practitioners, as we do not license them. And the newly issued telemental health guidance only applies for Medicaid reimbursement during the declared disaster emergency. I think we're just having a little trouble advancing our slides. There we go. Okay, all right, next. So we'll keep going. So during this time of the declared disaster emergency, the definitions of telemental health have been expanded as follows. So telemental health for Medicaid reimbursable services, temporarily expanded to now include, as mentioned already, telephonic and video, including the technology commonly available on smartphones and other devices. We've also expanded the definition of telemental health practitioner during this time to include any professional, paraprofessional, or unlicensed behavioral health staff who deliver a qualified service via telemental health. Licensed and designated programs through OMH can deliver services through phone or video as long as they're using staff allowable under current program regs or state-issued guidance as medically appropriate. I'm going to turn it over to Nicole.
Thank you, Amy. So the current telemental health guidance applies to the following programs of the OMH licensed services.
Slide to advance.
Okay, I'm going to continue on as they're working on the slide. OMH licensed clinics, CCBHCs, PROS programs, ACT, continuing day treatment, children's day treatment, treatment apartment programs, and partial hospitalization. For OMH designated services, CFTSS, Adult Behavioral Health HCBS, Adult Behavioral Health HCBS eligibility assessments, and recovery coordination services.
Jump in one second.
Go ahead, Bob.
This is Bob Meyers. I just wanted to indicate we specifically developed the guidance this way because this is focusing on Medicaid billable programs that aren't required to provide 24-hour on-site assistance. We didn't want to confuse everybody with bundling things together, and this guidance does not address a deficit-funded program, which normally you would be funded on a quarterly advance basis and providing care, but you're required to see people face-to-face. We will be issuing guidance on those, but we didn't want to confuse 24-hour requirements, and we didn't want to confuse contracted versus Medicaid programs. So that's the logic of why this is structured this way.
Thank you, Bob. Amy?
So just to focus on the guidance itself and the self-attestation, and as Rob had mentioned earlier, similarly for OMH, telemental health has been available for our providers for quite some time, and we did expand it. So really what our initial guidance was designed to do was just to give a rapid approval process so that people could start delivering services via telemental health pretty much immediately. We did update our guidance, and as we mentioned already, we expanded the definitions of telemental health and the practitioners that can deliver the service. As Rob already mentioned, similar for us at OMH, if you're already approved to offer telemental health, then you can take advantage of what this additional guidance allows. You're already approved, you don't need to let us know, just go ahead and do what you need to do. For programs and agencies that submitted the original self-attestation that we had designed, now that we have an updated version, you do not need to submit a new self-attestation. What we have on file will cover you. You're good for that. Also, we just need one attestation per agency. We don't need for separate providers, practitioners, just clearly identify the programs that are going to be covered so that we can make a note of that and just be aware of how you're delivering the service. Also, just keep in mind that even with all of these waivers and guidance that are out there, we still need to make sure that confidentiality and HIPAA are in place and that we're making sure that we're covering that. And also at OMH, we are also encouraging submission of attestations from all of our programs.
Thank you. There's a lot of information out there right now, so we are trying to focus for the purposes of today's webinar on telehealth. But other state guidance related to COVID-19 that is important for folks to reference is mostly on the OMH website right now. We recommend that you check the website and the link provided here daily, as it is continuously updated as we are able to get information out to you. That is the most accurate place to look. I know folks like to print out things, which is helpful, especially if sharing with staff, but you do want to continue to reference our guidance and our website daily for the most current and up-to-date. On a related note, DOH issued COVID-19 guidance for health homes. We just wanted to call that out today because it does reference the waiver of face-to-face requirements for all of health home care management. And we want to note that that includes individuals receiving assisted outpatient treatment, or AOT, as clinically appropriate. I'll go to the next one.
Yep, and I think we wanted to touch a little bit on some of the questions that we're seeing the most, which maybe will help to get ahead of that for tomorrow. Bob already mentioned one regarding the location issue. So any of those limitations and restrictions pertaining to location for the telemental health practitioner while providing service via telemental health are waived. And then also, we've got a lot of questions about how soon you can start delivering the service. And as long as you're meeting the requirements outlined in the guidance, you may begin utilizing telemental health immediately. Please keep a record of your attestation. You will also get a confirmation email from me. Just be aware that it is taking a little bit of time to get through the emails, but we will respond just to confirm that we have it. But you are able to start delivering via telemental health immediately once you've submitted the attestation.
Thank you, Amy. A few additional FAQs we wanted to get out immediately. Again, and Rob referenced this earlier, but it also applies to OMH programs. Is verbal consent allowable to begin telemental health services, or is written consent required? Verbal consent is allowable during the disaster emergency period. Please, of course, document this consent in the client record. Also, we are receiving a lot of questions about the telehealth guidance being applicable to adult behavioral health, HCBS, ACT, and PROS providers, especially in cases of individuals who are not licensed. And the answer is yes, all practitioners, professional or licensed staff, as well as paraprofessional or non-licensed staff providing these services are included according to the supplemental guidance. And we do encourage you to reference the full guidance document for all details that this webinar is referencing. Services delivered via the expanded telemental health allowances must be aligned with existing program regulations and guidance, meaning you are providing the same service that you would using the telephonic modality or telehealth modality. We can go to the next one. Thank you. And our face-to-face requirements for individuals receiving AOT care management, including ACT and Health Home Plus waived. As referenced earlier, DOH has waived all Health Home Care Management face-to-face requirements. This does include AOT, and we just ask that folks use discretion when doing this. We want people to be safe. We understand that there are individual circumstances at play here, and so we ask that you use your clinical discretion in determining when a face-to-face would be appropriate or not. ACT is covered in the supplemental guidance as well and also applies. And lastly, should providers use the GT or 95 modifiers? We saw this in the OASAS question as well. Only when both audio and video telecommunications are used to provide services, and the answer is no. During the emergency disaster, providers must use the GT or 95 modifiers for either telephonic or video provision of services, despite the modifier definitions requiring video. And that concludes our portion. I'm going to turn it back over to McTack to conclude the webinar.
Just to make sure I'm unmuted at the moment. So this is Meg from McTack. I want to thank our partners from OMH and OASAS for walking us through this guidance. And just as we're wrapping up, I just want to remind everyone of a couple things. I know that there were a lot of people who signed up for this webinar, and not everybody was able to join. So we did record it. The recording of this webinar and the accompanying slides are going to be distributed as soon as it downloads from MCTAC's system. So be looking for an email with the link to the actual slides and the recording itself. So you might be able to share it with your colleagues who wanted to join but weren't able to, so that they can hear it as well. The other thing I want to acknowledge is that we got a ton of questions, and I want to thank you for sending those all in. As I mentioned earlier on the webinar today, we actually are not going to spend time on this webinar answering those questions. OMH and OASAS are going to get together immediately following this webinar, look at all the questions that came in, and then tomorrow at 1 o'clock, same time, 1 o'clock, we will be addressing the questions that came in. So thank you. Keep chatting in your questions as long as our webinar is running. The other thing I want to say is that if you think of another question in the next couple hours after this webinar has concluded, when we distribute the recording and the slides, we're also going to include the OMH and OASAS specific email addresses that you can direct additional questions to. So if you don't get your questions in the next couple minutes as we're wrapping this up, don't worry. There's still going to be opportunities to submit them to the state, and we'll hopefully be able to include those on the webinar tomorrow as well. So I think with that, hi Bob, go for it.
Hi, yes, well,
yep.
I just wanted to say I have gotten a couple of emails from individuals and even a trade group who wasn't able to get on because of the oversubscription. Now, obviously, those people aren't hearing what you're saying because they're not on. So I just ask that if you have a way to broadcast or post the fact that the webinar is recorded, because people that want to comment that couldn't be on might want to view the webinar first and then generate questions. So I think it's important we get it posted right away. We get word out there in a way that people that wanted to get on and couldn't will see it, and then they'll also know that they could submit questions. And then I assume we're recording the Q&A tomorrow too, right?
Absolutely. We'll be recording tomorrow as well. And Bob, we'll be sure to include in our email communication, we're going to send it out MCTAC and CTAC listserv-wide, so everyone will receive it, that if there are additional questions that people have after listening to the recording, where they can send those questions to. We'll be sure to emphasize that.
Thank you.
Of course, yeah. Anything else from our state partners?
This is Bob. I just wanted to, again, thank everybody that called in here. I mean, obviously, since it's oversubscribed, there was deep interest here, which I think means you're just very committed to continuing to serve the folks you've been serving your whole careers here. And again, I would just emphasize, please keep your virtual front door open, because people that are being discharged aren't connected to care. We really need to get them connected to care during this difficult time. And you'll also be helping the hospitals not getting backed up. You know, the governor again emphasized the wave that he is anticipating, and CEOs or hospital CEOs are actually having a call today to try to increase hospital capacity. So the community providers really need to step up to help people move through the hospitals that no longer need to be there for that reason too. Thanks very much.
Of course. All right, well, thank you, everyone, and we will see you all tomorrow at 1 o'clock to answer some questions.